Hello and welcome to our webinar this morning or this afternoon, depending where you are, on the impact of non-motor symptoms in the successful delivery of LSVT loud and LSVT big treatment. We're delighted to have you joining us, and my name is Cynthia Fox. I'm joined by my colleague, Heather Cianci, and you'll hear just a little bit more about each of us in a few moments. A few quick disclosures about our faculty. All of the LSVT faculty have both financial and non-financial relationships with LSVT Global. Non-financial involves a preference for the treatments we'll be talking about today, both LSVT loud and LSVT big. In terms of financial, myself, I'm an employee of, receive lecture honorarium from, and actually have ownership interest in LSVT Global. And Heather receives lecture honorarium and travel reimbursement from LSVT Global. Our plan for the webinar this morning are to go over a few logistics, present our content, address your questions, and at any time during the presentation, you can type a question into the question pane. And at the end of the presentation, I will review again how to go about asking questions. And then finally, when you log out of the webinar at the end of the 1 hour, there's a short survey. We ask you if you have an extra minute or minute and a half to fill that out. It certainly helps us prepare and improve our content for future webinars that we present. For any of you who would like to use this information for continuing education activity, and this is typically professionals who are speech, physical, or occupational therapists, these webinars are not ASHA or state registered for CEUs, but they can be used for self-reported CEU credit as a non-registered activity. So if you are, for example, a speech, physical, or occupational professional and would like to self-report your activity, email webinars@LSVT Global to request a certificate at the completion of the webinar, and we will send that to you. Licensing requirements for CEU activities differ by state, so you might check to be sure that this would apply. And attendance for the full hour is required to earn that certificate. Here we are. Again, my name is Cynthia Fox. I'm in the picture on top, so you know who is talking to you today. Just in brief, I am a speech language pathologist. I've been with LSVT Global since 1994, have participated in the speech research, have participated in the translation of LSVT loud to LSVT big. I'm a faculty for both LSVT loud and LSVT big courses, and also currently serve as CEO for LSVT Global. I'm joined by my expert colleague, Heather Cianci. She is a physical therapist at the Dan Aaron Parkinson Center in Philadelphia. She's an absolute expert in neurological physical therapy, in particular with Parkinson disease. She serves as a faculty for the Allied Health Team Training, as well as faculty for LSVT Global. So you'll get lots of good expert information from Heather just a bit later on during this presentation. Now we'd like to know who our audience is. So I'm going to launch a poll, and in a moment you will be able to see if it pops up. You will be able to select on your computer who you are. So if you're a speech therapist, a physical or occupational therapist, a person with Parkinson disease, perhaps a family or friend of a person with Parkinson disease, or somebody who doesn't quite fit into one of those categories. So if you can just take a moment, click on the poll, that really helps us know who we're talking to today. So I'll give just a few minutes to allow everyone the opportunity to figure out how to manage that poll. Okay, so it looks like we have a mixed audience. We have about 67% of you are speech therapists, 22% physical or occupational therapist, and 11% people with Parkinson disease. So we will keep that in mind as we talk so that we can be sure we're addressing all our audiences equally. And now just give me a moment to go back to our slides, which I think have now appeared. Here are the objectives for this webinar. First of all, we want to identify and describe at least 4 non-motor features of Parkinson's disease, and we'll actually describe quite a few more. The goal of this is just, if any of you are kind of unfamiliar with what symptoms fall in or under the umbrella of non-motor symptoms, we're giving you a very high-level overview of what that might look like. I also point out we're not talking about all of the non-motor symptoms, and so there will be some that may exist that we don't have the opportunity to touch upon today. We'll then explain how non-motor features of Parkinson's disease may directly or indirectly affect things like speech, mobility, activities of daily living in Parkinson's disease. And then the heart of what and the message we really want to leave you with as focus of this webinar is to provide examples of strategies that can be used in therapies such as LSVT Loud and LSVT Big to potentially address these non-motor features and hopefully improve treatment outcomes. So in terms of thinking about motor and non-motor impairments in Parkinson's disease, we tend to be very aware of the key motor symptoms: bradykinesia, slowness of movement; hypokinesia, reduced amplitude of movement; rigidity, tremor, and postural instability. And of course, the complex of bradykinesia and hypokinesia are key focus of LSVT treatments, which is to drive amplitude. But there are a whole list of non-motor symptoms that occur as well. So things like depression, apathy, and anxiety, cognitive impairment and dementia, impaired kinesthetic awareness, pain and sensory deficits, bowel and bladder dysfunction, sleep disorders, and sexual dysfunction. And we know that the combination of both these motor and non-motor symptoms can negatively impact speech, voice, swallowing, communication, mobility, balance, and activities of daily living in people with Parkinson's disease. So this is a common figure, I think, that's used to display visually how we see the motor symptoms above the surface of the water really are just the tip of the iceberg. And the non-motor symptoms, that deep depth of the iceberg that is under the surface of the water, are what many patients experience that other people don't necessarily see or recognize. We also know that these non-motor symptoms may manifest several years before the typical motor signs that we're used to, tremor, rigidity, actually appear. So the impact of these on communication, mobility, and activities of daily living is not trivial. Again, non-motor symptoms may appear early in the disease. They negatively impact performance and participation early in the disease, and often more than the motor symptoms. They exacerbate and interact with speech and motor symptoms. They're less well managed by medication. And I think one of the take-home messages here today, they're often under-recognized, which is why we want to bring this to the attention both of therapists as well as people with Parkinson's disease. So let's walk through a few of these non-motor symptoms. One of them are changes in cognition, and these can happen even in early Parkinson's disease. So impairments found in early untreated Parkinson's might be impaired processing speed, so thinking, attention deficits, maybe some visual spatial impairments, executive function, and memory impairments. The functional impact on process skills are things like impaired problem solving. It might not be as easy as it used to be. Difficulty multitasking, decreased mental flexibility, difficulties with decision making or planning and organizing. When we think about communication in particular, we know that sometimes these changes in higher cognitive function make it challenging. So slower thinking may result in slower response time to questions. And it's not uncommon for people with Parkinson's disease to feel frustrated when people don't wait or give them the time to respond. In terms of language, sometimes delayed word retrieval. It's hard to think of the word that you want to come up with. Difficulty shifting communication topics, initiating and expanding upon language, difficulties with language processing. So the combination of slower processing with increased levels of distractibility can lead to a loss of train of thought. And that's a common complaint some people with Parkinson's disease will have. You know, I'm in my conversation and then I kind of lose where that conversation was going. And this can make conversations longer and perhaps more difficult and unfortunately sometimes frustrating, both for the person with Parkinson's disease and for the communication partner or the listener. Depression is a reality in people with Parkinson's disease. Now, not every person will experience depression. Sometimes it can occur early in Parkinson's disease. Sometimes it may be very mild and can be treated with things other than medication. But if it becomes moderate or more severe, those are indications that perhaps there needs to be a referral so that the depression can be managed. Even if a person is not in the range of clinical depression, these can be emotions and feelings experienced by people with Parkinson's. A loss of joy in interacting, feelings of isolation or loss of self-efficacy, sometimes a decreased desire to start or participate in conversations. This can affect engagement in treatment sessions, making compliance and carryover with treatment activities and goals more challenging. Sometimes it's just hard to get motivation. People may not just want to give it a try, and this may impact cognition and quality of life. Dementia, not unrelated to some other sort of higher cortical function changes, this may occur in later stages of Parkinson's disease. And again, not every person with Parkinson's disease by any stretch of the imagination experience dementia. It also can be a key characteristic of Lewy body dementia, an atypical type of Parkinsonism. So here we have some, perhaps greater difficulty understanding directions. And one of the challenges sometimes for caregivers can be that the person with dementia may have decreased deficit awareness. They don't realize that they're having as many difficulties as perhaps they are. This can limit new learning and carryover, more difficulty in understanding compensatory aids and how to use them, things perhaps such as a walker. And it can also impact feeding behaviors and swallowing efficiency. So safety during eating may be compromised and need to be addressed. Apathy and anxiety. These sometimes may be some of the most challenging feelings that people with Parkinson's disease experience. You know, that I want to get better, but it's hard for me to get started. That motivation that may come with apathy. And anxiety that can be related to motor symptoms, medication, and a whole range. And these can result from withdrawal or result in withdrawing from communication and social interactions, which we certainly don't want people to do. We want you to stay as active, engaged as you want to be. Sometimes people feel a bit hopeless that, wow, is my speech or mobility or daily functional activities, is there any ability to actually improve them? Again, that can result in this loss of self-efficacy, defaulting to lower energy output despite the capacity of the person with Parkinson's disease to have more. And unfortunately, sometimes if left unaddressed, people withdraw from really meaningful activities, whether it's work-related, related to their hobbies, or related to their family. Now, fatigue, I think, is something that every person with Parkinson's disease experiences. And in fact, in a survey of people with Parkinson by Shalling and colleagues in 2017, it was the most frequently selected problem by people with Parkinson's disease. It affects everything: motivation, engagement, and interferes with carryover of treatment strategies, concentration, difficulties with conversation, impacts freezing of gait and vision, and it could put people at greater risk for aspiration. And this is when during feeding, food or liquid gets into the lungs and puts people at risk for pneumonia. So it's certainly a really important characteristic that we need to be aware of and help people with Parkinson's disease manage. Fatigue and sleep sometimes go hand in hand. We know people with Parkinson's disease can experience sleep disorders. These can range from daytime sleepiness, and too many naps during the daytime might lead to nighttime sleepiness. Also, there's REM, behavioral sleep disorder. As we know, sleep depression can affect concentration and memory. might affect levels of alertness and our ability to sustain attention for conversation or mobility or specific activities of daily living. It can impact consolidation and retention. And this is important for us to think about as therapists in terms of how we help people with Parkinson's disease learn best. It can impact airway clearance during sleep and may be caused by sleep disorders, and impacts energy that people have when they come in the door to be ready for therapy sessions. Pain is another consideration, and so pain can be musculoskeletal, dystonic, neuropathic, or radicular. It's been reported up to 76% of people with Parkinson's disease experience some kind of pain, and it may correlate with depression and poor quality of life. One additional item of pain not listed on the slide here can be pain related to communication, perhaps getting a hoarse or strained voice, and this may be related to using poor compensatory strategies for changes in communication. Orthostatic hypotension is another non-motor symptom that's important for us to be aware of as therapists, as well as people with Parkinson's. Now, this may be a side effect of the medications a person is taking, but it can also be an autonomic symptom of Parkinson's disease. It can lead to falls, a fear of falling, and increased mortality. So certainly something important to address. And it's estimated that the prevalence can be as high as 30% of people with Parkinson's disease may experience orthostatic hypotension. So at this point, you may be thinking, whoa, that's a lot to think about. And is there anything that can be done to help? And so here's where we like to really take the shift in the presentation to the positive and the fact there is hope and there are things that can be done. So from the perspective of therapists, speech, physical, and occupational therapists, we really see that we have a unique opportunity today in the world of people with Parkinson's disease, and we believe that we can make a difference. That difference might be direct treatment strategies, indirect treatment strategies, or sometimes helping you recognize the person with Parkinson's disease, recognize these symptoms so we can facilitate proper referrals. We know that rehabilitation today is becoming a routine part of management in people with Parkinson's disease, both to provide symptomatic relief, but also to improve function. So you see you have your classic neuropharmacological treatment, perhaps neurosurgical treatment, and right as important as those therapies are speech, physical, and occupational therapies. And these circles overlap because it's not one or the other, but it's the best combination of all that may help people with Parkinson's disease. We like to acknowledge that sometimes our behavioral treatments really help empower patients, perhaps beyond some of the traditional medical treatments, because it allows you to really learn a strategy that you have control over. So treatment strategies related to non-motor symptoms. Non-motor symptoms may impact treatment, and that's important for us as therapists as well as people with PD to recognize, but it does not make people with Parkinson's disease ineligible to receive treatment. We collectively just have to figure out opportunities to motivate and address, not ignore, the non-motor symptoms. And as I said, we can potentially do this through direct and indirect strategies. So the strategies that we'll present going forward can apply to any treatment that you, a person with Parkinson's disease, may be receiving, you, a therapist listening, may be providing. But our examples that we'll utilize here today are really related to the therapies we offer, LSVT Loud and LSVT Big. So I'll start with cognitive strategies, and then after that, I'll turn it over to Heather, who will take us through the rest of the presentation. So patient education sometimes can be important for these mild, early to mid-stage cognitive health. And these are just kind of some general good principles. Exercise, exercise is good for your brain. So exercise at a minimum, according to the American Heart Association guidelines, and there's certainly specific exercises related to treatments such as LSVT therapies or general community-based exercise programs that are out there for people with Parkinson's disease, dancing, Tai Chi, boxing, a whole range. Socialize, stay active. Even sometimes if you don't feel like getting out and doing something, oftentimes once you get there and engage, it can be valuable. So join a support group or keep up with the activities that you already do. Engage in cognitive training exercises and activities, and certainly your therapist can help guide you into which ones are better so that you're working your brain. Learn coping strategies, and occupational therapists really have a expertise in helping people with Parkinson's disease learn some coping strategies. Eating well, nutrition can affect cognition. Seeking out nutrition advice, for example, trying a Mediterranean diet has shown some evidence of helping with people with Parkinson's disease. And sometimes learning to take time. It may just simply take longer when doing tasks, and that may be a shift in allowing yourself more time and being forgiving for yourself that it may take just a little longer to get things done. When we talk about what we might do within our treatment sessions, we found sometimes with LSVT that perhaps we need to increase the dosage of treatment. So the traditional dosage is 16 sessions in 1 month's time. So that's 4 days a week for 4 consecutive weeks. Perhaps we need to add an additional week of treatment or perhaps more frequent follow-up, and that can be helpful for people who have more cognitive challenges. Reduce distractibility in our sessions. Again, always being patient, allowing that time for processing. Modeling our exercises and functional mobility with limited verbal explanations, and that certainly is a hallmark of LSVT treatments. Do what I do versus explaining. We may need to adapt or break down the exercises as needed, and LSVT therapists are trained exactly how to do that so we can scale our treatment from early individuals to very late stage individuals. Repetition, repetition, repetition. Absolutely essential for learning and keeping it simple. So one simple cue: think loud, think big. When working with dementia, many of those same strategies apply, but we may have the addition of needing additional assistance to be compliant with home exercise. So training care partners, needing more familiar reading materials or activities, more repetition of exercises. During mealtime, perhaps enhanced lighting and table setting contrast, and assistive devices and equipment may certainly be necessary. So here's just one example from LSVT Loud. You have a person with Parkinson's who has significant dementia. As a result, they have difficulty reading unfamiliar material. You've learned through your interview that, wow, this person is particularly involved in their place of worship, and that's very salient and meaningful to them. So thus we can select familiar reading passages, and they may need to be simple or shorter passages for him or her to read to keep the intensity of motor practice going while at the same time maintaining salient engagement of the person with Parkinson's. So with that, I'll now turn it over to Heather, who will take us through the remaining treatment things that we can do to address these non-motor symptoms. So Heather, I hand it over to you.
Great, thank you so much, Cynthia. And again, I just want to welcome everyone and thank you for taking time out of your busy schedules to really learn about something that is really important for people with Parkinson's to understand, as well as the clinical care providers who are out there. Non-motor symptoms are often described as some of the most disabling things. You know, we have the medication that really can help with some of the motor symptoms, but these non-motor symptoms can sometimes be a little more elusive and challenging to manage in one's life. So like Dr. Fox was saying before, there are a lot of different ways that we use as therapists, both speech, occupational, and physical therapists, to help people to really be able to engage in life and to keep up that quality of life. And this symptom complex of staying motivated and engaged in what is going on in the world around us can be really, really challenging when we couple all of those non-motor symptoms together. So when we talk about things like fatigue that can be just so crippling for people, on top of sleep disorders where people either have difficulty actually falling asleep or they have difficulty staying asleep. So their sleep is very fragmented and they're not getting really into that deep restorative sleep. Dr. Fox touched upon the depression, which can really make everything in life seem a little bit more difficult to do and a little bit harder to kind of push through and to really have that motivation to want to stay engaged, as well as that apathy and anxiety. People can be very fearful about trying new things and maybe not even feeling like they want to do the old things that they once were engaged in. So if we can collectively take the strategies that we use with LSVT, both loud and big, and overlap these things, then we really can kind of help to address these issues in treatment. And speaking for myself personally, the ability to really help people to fight through the non-motor symptoms and regain that quality of life is just so rewarding. So let's look at the next slide. And many of the times what we need to think about is not just how we're providing our program, but also where we're providing our program. So, if you are working with someone, you're a therapist and you're working with someone who really is having a lot of difficulty with anxiety during off times. And for those of you with PD, you know about the off times when medications are starting to trail off and it's time for the next dose. It can be very disabling for certain people. So sometimes we need to think about scheduling the treatment sessions during those best times of day so that we can really make the person feel as comfortable and as best supported as possible. If we're dealing with individuals who become very distracted, people who are, again, dealing with problems with the anxiety or, feeling kind of nervous about what's going on, we want to do our best to really make the environment very welcoming and motivating. So using softer lighting, we want to try to take away distractions. So it may be that someone who is feeling anxious and overwhelmed or someone who is having issues with depression is very highly distracted by lots of noises and lots of things going on in a busy clinic. So it may mean that we need to, as a therapist, remove person from that situation and go into a more quiet treatment room. And we want to make sure that the environment is comfortable so that people are feeling very safe where they are. It's really important for the person living with Parkinson's disease to have a good schedule. And I always talk to my patients about how important it is and how they understand and how really well versed the majority of them are in keeping that schedule for their medications. They know exactly when it's time for each pill. They know if they've missed a pill and they know what happens when that occurs. And I say you need to think about doing your exercises and your functional phrases and your functional components, and those are things that we use as part of both LSVT Big and LSVT Loud. We need to have a schedule for that. So, these are the days of the week that we are doing it. This is the place in the home that we're going to do it. This is the setup that we have, and this is when we're going to do it. And if we can kind of treat our therapy programs like we treat our medication, I find that a lot of people really feel that that is very successful for them. If we have people who are feeling, again, that depression or that apathy, if we can involve other members of their support team, so family members, friends, different staff, if it's someone who perhaps lives in a retirement community, what can we do to help motivate that person? A lot of times we have had some really nice success with having grandchildren help out. It's a very motivating thing for many older adults to be able to stay active in the lives of their grandchildren and younger members in the family. So having the grandchildren be a part of the sessions and saying, this is why we're doing these activities and this is why we want to keep pushing you to work so hard and to make you feel so supportive, because we want you ultimately to be able to do what you want to do with your life. And in the beginning, it may be that we really do need more support to kind of convince that person with Parkinson's to carry over what we're doing. Sometimes people can say to us, well, this feels a little funny, this feels a little crazy, you're making me talk too loud, or you're making me take too many big steps, or I would never get out of a chair like this in a restaurant. And maybe, they're really uncomfortable with that, but we need to really do a great job as therapists in educating not only the person with Parkinson's, but also the team of people around them to help them to see that what we're doing in therapy is only a small part of the piece. It's how we're teaching you to kind of change your way and your lifestyle at home. So there's lots of things that we can do to really give good support to these folks. Next slide. I think one of the best things that we can do as therapists is to really be positive with people. This can be a very devastating diagnosis for many people. It could be that, I've had several patients who have worked very hard their whole lives and they just retired and were ready to do all these wonderful things when the diagnosis came about. I have an equal number of folks who are, in their 30s, 40s, and early 50s who are raising families. And, this can be really a scary time. So we need to be very positive with people about what the effects of the LSVT treatments can do for these people, and know that we are working people hard, but there is really a physiological reason why we're doing that. So, if we have clients who are saying to us, these exercises are a lot of work, then I, as the clinician, really want to say, yeah, absolutely, these exercises are hard. They are a lot of work, but this is what's going to help you to have a better ability to communicate with your grandchildren. This is going to help you to be able to walk yourself to the bathroom. This is going to help you so that your wife doesn't have to help you button your coat or unbutton your coat. You have a life that you want to live and things that you want to do. So if you stick with me as the therapist and we work really hard together and we practice, the stronger all of these things are going to get. And I often say to my patients, you're going to feel worse before you feel better. If you think about anyone who has not done any kind of active program in any kind of exercise for a long time, you know that you feel sore and you feel tired, and it takes a while to kind of feel that kick in of everything that's going on. So if we're able to really teach people that we're going to get them over that hump and push them with that positive reinforcement, it's going to be great. So we have to get people to be energized. So again, that could be talking about manipulating the environment again. Maybe we need to have a room that's more brightly lit. Maybe we need to have positive music in the background. And we need to celebrate success. So it's really important when you're the person living with Parkinson's and you feel the way your body is moving and doing things, you have a certain feeling of what you're able to do. But as therapists looking in from outside, we're able to see those little changes every day or week to week. So we really want to celebrate those. So we want to make sure as therapists that we're talking to our clients about, you know what, yesterday you were able to keep the volume of your voice at this level, but today you're keeping it at this level. Or, you know what, yesterday I had to help you this much with getting out of bed, and today I really just kind of guided you lightly. So we want to think about how do we really celebrate the little goals and the little changes. And the role of arousal is very strong in motor learning. If we want people to lay down new thinking processes and to really understand what's going on and how to make those new movement programs go along, we have to keep people stimulated. So it really is important for us as therapists to have that very positive, persistent energy so that we can give our patients the confidence that they're going to be able to try and do what we're asking them to do. Next slide. And one of the things that really, I think, helps to motivate people is things have to be important. Things have to be salient, and they have to be engaging. If I went to therapy and someone told me that the reason we were doing therapy was so that, maybe I could relearn how to, rotate the tires on my car, and that was the goal, I would say, you know what, I don't do any tasks that have anything to do with my car. I take it to the mechanic. I'll tell you what I really want to get back into doing is learning how to knit again. Could you help me to learn how to knit? So if we incorporate things that are important to people and things that really help to motivate people, they're going to be more likely to do those things. So we always like to link why we're doing LSVT Big and LSVT Loud to what are the goals. I want to be able to do X, Y, and Z. Well, Mrs. Smith, this is why we're doing that. So think about the hobbies, think about the passions, think about the things that people use to help them achieve that self-realization, to be able to improve their communication, their function, and their participation. I think it's not just enough for people to feel better about what they're just doing in their own homes. I really do strive with my clients to get them to get out there and participate in the world. And I say, it's not just enough to be physically active, we also need to be socially active. And that gives us more opportunities to practice our speaking skills. That gives us more opportunity to be challenged out there in the world to use our mobility skills. So again, think about what's going on, help that patient with the other environmental factors that really can help facilitate motivation and learning. So involving the family, like I talked about. If someone is still working, then we want to see how can we help them to be able to continue to do those tasks and still have a busy schedule. And then again, incorporating hobbies. And I find that a lot of people will give up their hobbies much too early in the course of the disease, or they get frustrated because maybe because of the cognitive issues, they can't remember all of the steps. But if we involve the family and we involve friends, and they could possibly help to cue the patient, or the client to be able to do those hobbies better, then that's going to be, again, a really good motivating factor to stay active. Next slide. So Dr. Fox had mentioned before about the importance with staying active and having physical activity, especially when it comes to fatigue, all sorts of things that can help with just that prescription of how much dose and how hard we work. And we do know with research that physical activity and actively practicing what you're doing really can help to kind of increase that vigor. So it can help folks who are dealing with apathy and low energy. And increased activity with the treatment can actually help people with their sleeping schedules and help people to stay asleep a little bit longer. And it really does improve the ability for people to have their daily schedule and have more endurance so that they're able to do more. I love it when people report back to me and say, you know what, I was able to have a longer conversation with my neighbor today. I was able to stand taller. I didn't feel like I needed to sit down. I was able to be more outgoing and more talkative in my book club last night. You know, usually I kind of shrink back into the background and listen to the other folks, but I got right in there and I did my thing. And those are the little goals, again, of celebrating success that we want to do for everyone. So for the folks who are out there with Parkinson's, think about the things that you would love to really get back into doing. And by keeping up physical activity, even when we feel like sometimes it's a struggle, we know that there's a light at the end of the tunnel and those goals can really be achieved. Next slide. So when we talk about the management of fatigue, and again, fatigue makes everything harder. And I know it often sounds counterintuitive to folks living with Parkinson's for me to say to them, I know you're really tired, but this is the best time to exercise. But the studies are really showing us, and anecdotally, I can tell you this just from my own clients, is that when you fight through that fatigue with exercise, you actually can move better and feel better. If we keep ourselves really mentally and physically active, again, that helps with the fatigue, because sometimes fatigue can almost take the form of boredom, where people are thinking, you know, I don't know what to do. I'm sitting around, I'm watching television, I'm not stimulated enough. So if we keep a really good schedule of staying mentally and physically active, that can be beneficial. Something called good sleep hygiene, or having good sleep habits, that is also helpful for managing fatigue. And those are things like going to bed at the same time, getting up at the same time, keeping the bedroom on the cooler side, not keeping yourself tied down with lots of heavy blankets and sheets, but maybe wearing a warmer set of pajamas, limiting how much liquid we have after dinner, and making sure that the bedroom is really just for sleeping. We don't want to be talking on the phone in the bedroom. We don't want to be reading on the phone. We don't want to be watching TV. We don't want to be looking at our iPads. We want the bedroom to be seen as a place for sleep. And again, even though people are really troubled with the fatigue, it actually, it messes up the sleep cycle if people are having too many frequent naps during the day. So we always counsel our clients on kind of the best nap. And that means a nap where you are not sitting up in your chair with your head flopping down onto your chest, because that's going to aggravate any kind of neck issues and postural problems. If you're going to take a nap, you want to be lying down, and you don't want to go for any longer than 20 to 30 minutes. Staying well hydrated as well as eating well. So having a good diet to make sure that you have the energy that you need for that. And then we need to pace ourselves. We have to think a lot about the routine that we have. So maybe it's not a great idea to wait to do all of your phone calls to talk to your family and friends at the end of the night when you're most fatigued. Maybe we need to spread out those conversations during the day. And maybe because it takes so long to get in and out of the shower and do all of that AM care, and we're so tired by lunch, maybe if we switch to doing the shower and laying out our clothes at night, it's going to give us more energy for in the morning. So please, as therapists, know that there are strategies for this, and for those of you who are living with PD, we can absolutely help with this. Next slide. So I'm going to talk about a case example here of a gentleman that we worked with in our clinic who was having a lot of difficulties with many functional tasks, but his underlying non-motor symptoms were really making everything so much more difficult. And for him, it was really fatigue and apathy. Right off the bat, he was very honest with us that he was not enjoying activities that he really once found pleasurable and looked forward to doing. His motivation level had sank very, very low, and he was feeling tired all of the time. And he admits that he wasn't sleeping well because of issues with restless legs, and also the fact that he needed to get up and use the bathroom during the night. He already had an issue with chronic low back pain, so he was thinking that, you know, I better just take it easy, because if I exercise or I move around too much, it's probably going to make that back pain worse. He had issues with what we found out was not vertigo, but was actually the orthostatic hypotension, and that's where your blood pressure dips down quickly if you get up from a seated position or a lying position too quickly. So he was spending really most of his time just sitting around watching television, and he admitted that he had slowed down. So he had some insight into some of his deficits, but at the same time, he was starting to also blame it on his wife and saying, you know, it may not just be me, I think she's walking too quickly too. So let's take a look at the next few slides and we'll talk about what we did to help with him. So one of the first things we did was we set a schedule for his home program. So that meant, just like he had a schedule for what time he was going to take his medications, he knew what time of the day and where in the house he was going to complete that. He also was really helped by using the Homework Helper DVD, and we have those available for the LSVT Loud and Big. So this is something not only can patients and clients use the DVDs, but we also can do that on a streaming service, so people can do that through their computers. And we tried to think about, you know, what was meaningful to him. He had stopped doing things that he enjoyed before, and when we talked with him, he said, you know, I want to play with my grandkids more. You know, I'm not getting out there to their baseball games and even just playing with them out in the backyard. You know, my wife and I really love to travel and eat out. So we said, you know what, if these are the things that are important to you, we're going to make these your goals. We gave him a lot of reinforcement. So we were talking about how when he works really hard and he gave us that really good effort, that was going to actually improve his quality of life. And we talked about how he needed to work harder to make this happen. And we talked about it every day and we tracked it each week. One of the other things was we talked a lot about education on the difference between muscle soreness versus pain. So a lot of what he was actually interpreting as a irritation or an exacerbation of his low back pain was actually normal muscle soreness, that the more active he became, the better it got. We also talked about the difference between fatigue that came from normal exercise versus the other types of fatigue that he was dealing with. That actually it was good to feel a little breathless, it was good to feel a little sore, and it was good to feel a little bit drained after you did your exercises, but that there would always be that rebound. We again talked about sleep hygiene, and then we were always constantly highlighting how his exercise was actually improving his sleep and boosting his energy. So he would tell us little stories of, you know, I walked a little further today, or I didn't nod off during dinner, or I was able to carry on a longer conversation at the dinner table. When it came to dealing with the orthostatic hypotension, we of course pulled his physician in right away, talked about increasing the hydration during the day. He ended up wearing compression stockings, and we taught him how to make his movements, you know, not to just jump right up out of bed when he was lying there for a while, but slowly sitting up on the edge and doing some warm-up exercises. And then again, we reinforced any of those positive changes in his movement so that he could really start to feel like and internalize what normal movement would feel like. Because remember, he was saying, you know, well, maybe I've slowed down, but it might be just that my wife is walking faster. And we know as therapists that is not the case. She was not walking faster. His movements were too small and therefore too slow. So we were able to use a lot of videotaping to show him before and after on how his movements looked. Next slide. So like this gentleman who was dealing with issues with pain, we want to think as therapists, what are the kind of strategies? Well, we want to think about, we need to model and reinforce really good biomechanics and voice quality. So, we are not overstraining joints. We are not overstraining the voice. We are not having people yell. We are not having people try to push through chronic problems. And we have to adapt what we're doing. So we're not looking to cause pain. So if we have someone who, perhaps had a frozen shoulder and they're not able to get the arm past a certain point, we're not here to say that LSVT big is going to break through that. So we have to be careful about how we adapt so that we can not cause that pain or cause any difficulty with the vocal quality. And we have to support. So that means that we have to add help. So that may mean that we need to have someone not perform some exercises in the standing version. Maybe they need to hold on to something, or maybe they need to be seated. Maybe we need to have someone there with them. Maybe it's too much for people who are experiencing dementia to be expected to remember every single thing that we're giving them. And then we bring in a care partner or someone else to help to cue them through their voice exercises and through their functional components and functional phrases. If we're having people who are having pain or vocal strain, then we're not going to ask them to hold things quite as long. We're going to bring that down. We're not going to push through so many repetitions. And we have to be very aware for screening for other conditions that may need actual treatment before LSVT big or LSVT loud, or then after. I've had quite a few patients who have had some issues with diabetes that was not managed well, and people who were also having issues orthopedically that were not being managed well, sending them back to their physician or to an orthopedic physical therapist to kind of take care of those problems before we went through the full LSVT big program. Next slide. So when we talk about orthostatic hypotension, I had mentioned a couple things that we had done with the gentleman before, but one of the other things is we have to think about when people are avoiding toileting. So meaning that, I'm afraid to drink a lot of water because I'm afraid that I won't get to the bathroom on time. I'm afraid because I feel like I have problems with my bladder control, or I'm afraid because I don't think I can actually walk to the bathroom quickly enough. So that goes into a lot of our education about bowel and bladder management. And again, always pulling in the physician to think about what other kind of medical management can we do, and can we do any kind of compression wear with people. There are people who actually wear abdominal binders as well as the compression socks. Next slide. And there are things that we can do that are actually non-pharmacological, meaning not medication-based, for assisting people with anxiety. And you can take a look at this chart here through the Parkinson Alliance in 2018, where look at that first one there, 69%. You can get an improvement by exercise. There are things in there using music, relaxation, using pet therapy, using massage. So there are lots of coping techniques that are out there that people may not be familiar with, and we as therapists need to educate people about this. So know that there are different ways. There is a great system review of the impact of physical activity on non-motor symptoms, and we know that that helps with depression, apathy, fatigue, cognition, and sleep. But we know that we do need further research to clarify what kind of exercise, how much exercise, and some of those other contributing factors that do impact. Let's take a look at the next slide. And this is a wonderful quote from an LSVT loud clinician. I do believe that as patients begin to see positive results from therapy and hear positive comments from others, that their confidence increases, which impacts their ability to cope with anxiety, depression, apathy, etc., and everything better. So those positive results really do impact the quality of life. Next slide. So remember, why is it important to consider and talk about non-motor symptoms? They're all barriers, potential barriers to the ability to have better quality of movement and better voice volume outside of the treatment room. They are part of the reason that high intensity repetition and importance of movement and voice quality are so important. And we as clinicians need to look at the person with Parkinson's as a whole person, not just one symptom. It's non-motor as well as motor symptoms. Next slide. So as therapists, please don't fall into these potential pitfalls and get lost with all of the different issues that people with Parkinson's have. We know that there are many different things that people are dealing with and can be very troublesome. But the single focus of what we're doing with the LSVT treatments is still amplitude. And the greatest gift that we can give our people with Parkinson's is to be able to improve their communication, improve their quality of life, improve their swallowing, have people have better ease of mobility, and then getting people out there to have more participation in their life. Next slide. Know when to refer. So it really does take a village. Let's take a look at the next slide and talk a little bit about when it's time to send people. So the LSV Loud clinician again says, we're the eyes and ears for the nurses and doctors. We actually get to spend more direct time with our patients and may become more aware of the non-motor symptoms. We need to be educated and relay information in a professional manner. So because we're lucky enough to spend time with you, we get to then send this information back out to the rest of the village. So the Parkinson's disease medical team, the neurologist, it may be the gastroenterologist, the pharmacist, and then the PD ally team, your PTs, OTs, speech therapists. If you're lucky enough to have nutritionists, social workers, sex therapists, and then just within that community, the support group leaders, the people who are running exercise classes, and any of the complementary therapies that are out there. Next slide. So in summary, non-motor symptoms are pervasive in Parkinson's disease at all stages, and they really do affect communication, swallowing, mobility, and activities of daily living and quality of life. But we as clinicians really can impact those non-motor symptoms, both directly and indirectly, with the way that we facilitate our treatments. And we need to, as clinicians, view the whole person, but again, focus on what we're specialized to improve. And that the best care that we can provide people really does take a multidisciplinary team. And we know that we need systematic research on the impact of both LSVT loud and LSVT big therapies on non-motor symptoms, and we are rapidly moving in that direction. So what I'm going to do now is hand this back over to Dr. Fox.
Thank you, Heather. So we'd like to, before we open it up for questions, is to share a video with you that I think we always find inspiring. And this video is Sharon, and she's a woman with Parkinson's disease. When I first met her, she was still working full-time at a very sort of high-powered pressure job, director of communications for a major university. She was newly diagnosed, so very early in her Parkinson's, and her father had Parkinson's disease. And so despite the fact her mild symptoms and early diagnosis, it was a classic case where her quality of life was not what it should have been. Some of that was fear, anxiety of the unknown, having seen what her father went through. She came to us, she received both LSVT loud and LSVT big in consecutive sessions over the course of a month, and she came alive. This video that you'll see is actually 8 years after she had initially had those symptoms or treatment, and she had since retired from the university, and now she spent her time writing and performing raps about Parkinson's. It was kind of a creative outlet for her. And she was, I always think of her, one of the most sort of masked face, or not most, but she had a considerable masked face, and in terms of treatment, maybe somebody, a therapist would have shied away from pushing her, and that's, again, the exact opposite of what you need to do. And so this video, I think, will share the empowerment that we as therapists can offer for people with Parkinson's disease. Take it away.
This is what LSVT sounds like 8 years later. Yo, homies, listen up. Well, I've got my bling and I've got my cap. I'm the L-Dopa Diva and I'm here to rap. When I say what? Say what? What? Say kick Parkinson's butt. Say what? Say what?
Kick Parkinson's butt.
Say what? Say what?
Kick Parkinson's butt.
But when your voice is scratchy and your volume is low and people say, speak louder wherever you go, the unlikely treatment is to bellow endless ahs, over and over without any pause. Dr. Fox is relentless, she says in terms gruff. If it sounds too loud, it's just loud enough. When I say think loud, you say, ah, think loud. Ah. Well, our hands are shaky and our pace is slow and we have hallucinations and our feet won't go. But if we can laugh at ourselves without much fuss, we may have Parkinson's, and I'll never have us. When I say Parkinson's, you say don't give in. Parkinson's.
Don't give in.
Parkinson's.
Don't give in.
Parkinson's.
Don't give in.
I'm down with that.
Okay, so I hope that provided a little bit of inspiration there from Sharon that we were able to see. So at this point now, we'd like to move to questions. So if you have questions that you would like to ask, you can type in the question box that's in your control panel. Let me just double check here. Okay. You can also, there's a little icon where you can raise your hand. Your name will be called out. Your mic will be unmuted. And make sure you have your mic unmuted as well. And you can ask your question out loud. And then we will be able to answer it that way. So we have a few minutes to take questions before the webinar concludes. If you think of a question at any time after the webinar is over, you can email that at any time to webinars@lsvtglobal.com, and one of our expert faculty will be happy to get back to you and to be able to answer that question. So for the first question, and Heather, I'll give this one to you. The question is really about knowing when to refer and what are key signs or when do you really feel that, gosh, what I'm doing isn't enough. There's not a specific symptom necessarily listed here, but perhaps you can give us a little bit of your insight from your vast experience about instances when you knew it was time to refer.
That's a great question. And I'll take it from a couple different standpoints. So if it's someone with orthostatic hypotension, if the different changes that we're making in the positioning of the person, so maybe if we're doing LSVT big and when we do the floor to ceiling, we put our head down and then we come back up and we adapt that and take that portion out, but just work on reaching out and then up and back. If that's not helping the person, if the person is continually feeling very fearful of what they're doing because of the orthostasis, and that's preventing them from doing the home program, then I'm going to refer them right away to the doctor. That's a big one. If the patient is not able to do what I need them to do to carry over at home, and the things that we've been doing in the clinic aren't enough, then that's absolutely a reason. If I have people who are, you know, with the cognitive issues, who are becoming angry, or they're becoming increased kind of in their defensiveness about things, that again, that's probably one of the reasons that I would refer someone back.
Excellent. And just to follow up on that, when you make those referrals, does therapy continue in that process, or are there times when that results in a break from treatment, the symptoms are managed, and then they come back?
Fantastic. I would love to give you a blanket answer on that. It's been a little bit of both. Some people actually do need to stop therapy to get some of those issues under control. Sometimes we're able to get them in to see the physician, and it may be a change in the medication. It may be simply going to the compression stockings. It may be that they actually need to, you know, I've unfortunately had patients who needed to be hospitalized for issues with severe depression. So it really is going to be up to you, the patient, and the physician together to make that clinical judgment.
Great, thank you. We have time for one more question, and this will be one I can take. Does LSVT improve swallowing? I know you mentioned swallowing throughout, and is that something that we can use to address swallowing impairments? LSVT is not, LSVT loud in this case, is not considered a treatment for swallowing. There are tried and true evidence-based therapeutic protocols to address specific issues with swallowing. So any concerns about swallowing should be seen by a referral for a swallowing evaluation by someone who has expertise in swallowing and Parkinson's disease. Based upon that evaluation, there may be direct swallowing techniques that are given. There may be direct swallowing exercises that need to be done specific for the swallowing disorder. And so we always say that is our first course so that we have safe swallowing and we minimize any risk for aspiration pneumonia. That being said, we do have some pilot data from our laboratory, another sort of pilot or preliminary study from a laboratory, I believe out of Australia, that have shown after LSVT loud, some aspects of swallowing have improved. Some aspects with the oral phase of swallowing, controlling food or liquid in the mouth, some aspects with cough or clearing after LSVT loud. We consider those ancillary benefits, additional benefits, but they don't replace the need for direct specific swallowing therapy delivered by someone who's an expert in that area. Okay, with that, we are right at our 1 hour mark. We certainly thank you all for joining us today. Just a reminder, when you close out of the webinar, the survey should launch. If you have just an extra minute and a half and you can fill that out, we appreciate it. We look forward to you sending any additional questions that may come along and hope to have you join us next month for our public webinar. Thank you.